Lovely. Well, thank you everyone for attending. Great to see so many people who are on the call, and welcome along to a little webinar that we're hosting today on CVD, healthy heart checks and CORE20PLUS5 communities. My name's Mark Henderson. I'm the Associate Director for Health Improvement at Health Innovation Northeast and North Cumbria. And I just want to take us through a little bit of housekeeping over the next 60 minutes. So please ensure your microphone and video are turned off during the session. If you need to take a break, get up, move around, we'd encourage that. If anything isn't working on your Teams, I would say the first action is to drop off the call and log back in, because that generally works with Teams. We are recording the event, so hopefully everyone is okay with that, and we'll be able to share that afterwards. We are going to hold questions to the end, and I really want to make sure that we have time for questions at the end. So by 1:50, we'll ensure that we've definitely got 10 minutes for questions and engagement after we do our presentations. Just going to run through our agenda for the next hour. So I'm going to kick us off with a bit of a background and an overview of the Healthy Hearts programme. Then on the call, we've got Dr. Sarah Malik, who is the CVD clinical lead at the Northeast North Cumbria ICB. And Dr. Malik will be looking at the importance of health checks in the prevention agenda. Then we've got Dr. Nez Robson, who is a GP in Densham and Dovecot surgery in Stockton, and Dr. Robson will be taking us through real world experience of running Healthy Heart Checks Clinic. And then Tracy Marshall, who is our programme manager in the cardiovascular disease team at Health Innovation Northeast North Cumbria, and has a background as a pharmacy technician, and will be doing a short part on reasons to take part. And then we will continue with questions and answers. So if you've got any questions as we go along, pop them in the chat, but we will take questions at the end. So I just wanted to give a little bit of a background as to how we got here. So around 18 months, NHS England engaged with all of the health innovation networks across the country, of which there are 15 of them. And they launched a programme called INHIP, and INHIP stood for Innovations Within Health Inequalities Programme. And the purpose of the programme was to work together with local communities to co-design interventions to minimise healthcare inequalities and also improve access to the latest health technologies and medicines. So we chose to focus our project. It was a 12-month project in cardiovascular disease, because that's part of the CORE20PLUS5. And we know that those who are living in the most deprived areas are almost 4 times more likely to die prematurely of cardiovascular disease than those from the least deprived communities. So we did a behavioural insights piece of work. We engaged with 3 communities and their community leaders from the South Asian, Black African and white underserved groups. And our goal was to engage with these communities and their leaders to understand access to NHS health checks and to look at innovative ways of delivering them within these communities. And so we know that uptake of NHS health checks isn't where it needs to be. And Dr. Malik will probably expand on that as we go on through the conversation. But it's especially acute in these underserved communities. So we need to focus on co-designing an innovative approach to help improve uptake of NHS health checks in these communities. So we co-designed a number of interventions with the community leaders. We didn't have time to implement all of them, but we implemented one intervention which was looking at taking healthy heart checks into those communities, taking them into the local mosques, taking them into the local community centres, to the women's only fitness centres, and into the churches. And the outputs of the work were great. Over a 4-month period, we performed nearly 600 healthy heart checks. One of the big things is that we had a really high uptake. So we had 87% uptake, and a lot of that was due to that co-design work and the support that we had from community leaders. And those who were at high risk of cardiovascular disease were referred back to their GP. So at the end of this piece of work, we performed an evaluation and we presented it to the Healthier and Fairer Programme Board at the ICB to see if we could do this at scale. And here's a little bit of the feedback. I'm not going to read those quotes for you, but I think a couple of the things I want to take from this is that co-design and working with local communities was key to it, working in partnership. And the other thing I want to kind of highlight is that we really wanted to focus on people who were not really engaging with the traditional biomedical model of accessing healthcare, and that's a couple of the things that we achieved. For those of you who are a bit unsure of what health innovation organizations do, we work with companies to bring their ideas, develop their ideas, evaluate them, and bring them into the NHS. And one of the things I didn't mention about the Healthy Heart Check is that we implemented and evaluated POCDOC, which is a point of care cholesterol test. It provides you a 5-marker lipid panel within 7 minutes, and I think that was really important as part of the outreach stuff. So we implemented POCDOC as part of our healthy heart checks, and then we took it along our innovation pathway that you can see, which focuses on taking an idea, developing it all the way to regional adoption and spread. I'm not going to go into too much detail with regards to this slide, but the Healthy Heart Check program is focused on CORE20PLUS5 and engaging with those communities within the 20% populations that are in those most deprived areas. It links with the ICB's clinical condition strategic plan, which I'm not going to go into too much detail about, and the 2025-26 priorities and operational guidance from NHS England. I'm going to scan over this slide, but because we've got Dr. Malik on the call, but obviously it's in alignment with the ICB's CVD aspect of the clinical condition strategic plan, which is about proactively managing risk factors, proactively case finding, timely access to diagnostics and effective treatment as well. So what is involved within a healthy heart check? So there's a number of similarities within the NHS health check, but i.e. we focus on height and weight, blood pressure check, point of care cholesterol testing, and I've mentioned POCDOC before, point of care HbA1c testing, and really one of the most important elements of it is that education, having time to have a conversation with the individual on cardiovascular disease and its risks, but also focusing on other areas of health education, such as smoking cessation, alcohol, and all of those other really important aspects of encouraging people to self-manage their health. We have a referral criteria for those with primary prevention, their total cholesterol being equal to or greater than 7 millimoles a litre. For those with secondary prevention, the non-HDL cholesterol equal to or greater than 2.5 millimoles a litre. For those with raised blood pressure, where three readings have been taken and the blood pressure is still raised. For those with a Q risk score equal to or greater than 10%, which indicates them having a risk of having a heart attack or stroke within the next 10 years, and those with a raised HbA1c. So the aim of the program is to, reduce cardiovascular disease by encouraging engagement with the CORE20PLUS5 communities in CVD risk reduction strategies, and working with people, and it's great to see so many people on the call this afternoon to see how many people are keen to be engaged in this piece of work. So I'm going to focus on the first element of it, which is that we want to scale healthy heart checks across Northeast North Cumbria, especially in those underserved PCNs. We're doing that through an outreach approach, but we also want to engage with GP practices and PCNs as well. There are a couple of other elements within the program as well about piloting point of care testing in annual physical health checks for those with severe mental illness. We know that people with severe mental illness have a greater risk of poor physical health and die on average 15 to 20 years earlier than the general population, which is just an awful statistic. We know that that is getting worse with a widening gap in death rates over time, and that this can be prevented. 2 in 3 deaths with those with severe mental illness can be prevented, with the major cause of death being cardiovascular disease, respiratory disease, and diabetes. So we want to help see if we can support in that space. And same with those linking in with targeted lung health checks. And we know that 70% of lung health check patients have coronary artery calcification, and that many of these patients are at high risk for cardiovascular disease, but may not be currently on the primary prevention lipid pathway. So we want to support with that as well. So there's a targeted approach to engagement. Thank you for coming along today. Our colleague Jack at the ICB has helped support us with data from CVD Prevent and Radar and the Shape Atlas tool. We have looked at the data across the region, and I'm not going to go into great detail about it today, but focusing on those indicators around treatment of hypertension and treatment of cholesterol, and aligning that with deprivation risk as well. So the objectives are to increase the delivery of healthy heart checks across NENC over the next couple of years. We want to develop a joined up model of care for healthy heart checks to create service efficiencies and really have an improved experience for the service user. We want to develop a workforce training package. We have already developed a suite of healthy heart check resources that are in alignment with health literacy standards, and we want to focus on upskilling the workforce within GP practices and outside of GP practices as well. And all of that leads to hopefully improving the uptake of anticoagulants, hypertensive medications, and lipid lowering therapies as part of CVD prevention. And throughout all of this work, we are focused on providing an evaluation of the program with a health economic analysis as well. So these are a couple of photos of the outreach buses that we've engaged with at Newcastle GP Services and the Ralph bus from Hartlepool and Stockton Health Federation. And Tracy Marshall, one of my colleagues, has been doing a lot of engagement across the patch just even over the last kind of 2 to 3 months, taking the bus to a number of different areas. And so, you know, we launched this program towards the end of last year. Most of our work so far has been in developing the outreach approach. Now we want to engage with GP practices around how we can scale this within GP practices and PCNs, and you'll hear a little bit further around that over the next 30 minutes. But one of the main things is that we have delivered some healthy heart sessions within Densham and Dovecot surgery, and Dr. Nez Robson will share a little bit more about her experience of that within the call. And just this kind of is my last slide. We want to engage GP practices and PCNs, like you mentioned, but we've also engaged community pharmacy as well, because we believe that community pharmacy is really well placed within the prevention element of this arm as well. And, you know, the community pharmacists, they know their population, they know the people that are coming through their doors. And we are scoping out the possibility of delivering healthy heart checks at Appleby Fair in June as part of our inclusion health approach. So I've whistled through that to give a little bit of a background and an overview of the Healthy Heart Programme. I'm not going to have questions. I'm now going to introduce Dr. Saira Malik, who's going to be speaking around the importance of health checks in the prevention agenda. So Saira, do you want to share slides, please?
Yes. Mark or Jack, will you just let me know that everybody can see that, so that I'm not just forwarding it on my screen?
Lovely. And that's all working perfectly. Thank you.
Thank you, Mark. Good afternoon, everybody. My name's Saira Malik. I'm a GP in Sunderland and the North East North Cumbria ICB CVD clinical lead. I have my colleague here, Jack Ryan, as well, who's our management lead. So any questions, feel free to direct them to him. So I'm just going to go through some kind of contextual information about cardiovascular disease in the North East North Cumbria area, and also some information that we have about health checks. It's great to see some familiar faces here and the opportunity to make new acquaintances as well. So NENC in a picture, obviously we know that the North East North Cumbria area has poorer health outcomes and greater health inequalities compared to other areas in England. We know that the gap in life expectancy, as Mark outlined there, is widening with a variation between the most and least deprived areas within the North East North Cumbria. And the largest contributor to this gap is cardiovascular disease. There's also rising rates of cardiovascular disease in our region, and that's driven by socioeconomic factors, lifestyle choices, and healthcare access. I think it's really important to kind of reflect on the amount of research data that the ICB holds, and we know that 1 in 3 individuals in our area, mainly women, live in poverty, and we know that poverty limits choices, creates poor health, and increases dependence on healthcare services. Cardiovascular disease really does exacerbate obesity, hypertension, diabetes, cancer, all of which we know are also linked and risk factors for cardiovascular disease. And we also know that pressure in the healthcare system creates health inequity, in that services struggle to enable early diagnosis and treatment of cardiovascular disease conditions, which just means that there's worsening outcomes. And that's where the health checks will come in as a very valuable modality of engaging with our patients. So the data tells us that the rates of cardiovascular conditions are higher than the England average. So we're looking at stroke, hypertension, heart failure, CKD, chronic kidney disease, coronary heart disease, and atrial fibrillation. They are all higher prevalences in our region. And we know that circulatory diseases account for 15% of all our emergency admissions, which roughly equates to 5,345 monthly emergency admissions over our area. We know that the risk factor frequency is increasing, and we already know that 20% of our regional population, which is approximately 625,000 patients, have 3 or more risk factors for circulatory disease, and it's rising. So just looking at how we're doing with the risk factor optimization. So we take the ABC approach, which is atrial fibrillation, blood pressure, and cholesterol. And we know that we're performing quite well in terms of our primary care colleagues recording hypertension and then trying to ensure that patients are on the appropriate treatment or being treated to target. But as you can see from the percentages depicted there is still work to be done. So just looking at the inequalities, we've been looking at atrial fibrillation, and we know that patients from Asian and mixed ethnic groups are less likely than their white and black group counterparts to be treated with anticoagulants, and there's no significant difference in deprivation for the treatment with anticoagulants. Looking at blood pressure, we know that patients from black ethnic groups are less likely to have blood pressure treated to target compared to other ethnic groups. And those in the most deprived areas are less likely to have blood pressure treated to target compared to the least deprived. And when we review cholesterol, patients from Asian ethnic groups are more likely than other ethnic groups to be treated with lipid-lowering therapy and treated to target. And the most deprived areas are more likely to be treated with lipid-lowering therapy, but the least deprived areas are more likely to be treated to target, which feels a little bit against the grain of what we understand is happening with our inclusion groups. But obviously there are geographical inequalities across our GP practices, PCNs, and sub-ICB areas. So just looking at our area and health checks, we have approximately 740,000 patients eligible for health checks, which is approximately 24% of our population. And 8 of our local authorities, unfortunately, are less than the England average value of achieving their targets. So of approximately 67% of patients invited to attend a GP practice for a health check, only 36.2% took up the offer. I think the ray of sunshine in this is that there has been an increase in patients uptaking health checks when we compare to 23-24, and there has been an approximately 19% increase in our area, which we want to continue working with. And again, just looking at the figures there, we can see that there has been an increase, but we just want to keep pushing that further and faster forward. So here we're just looking at NHS activity data across our region, and we can see that there is a variation in patients attending. I'm not going to single out areas, I don't think that's right, but I'll just share the information there for everyone to have a look at. And Jack and I will be planning some more information to be sent round to all our PCNs and primary care colleagues to see how we can help this further. Obviously, there is a variation in patients being offered health checks across our region. And we know there's been an increased drive in Newcastle, Hartlepool, Sunderland, and there's been a reduction, perhaps some additional help required in other areas. So obviously, why do health checks matter? I think I'm preaching to the converted here. We know that targeted prevention helps drive down health inequity and health inequalities. We know that raising education and awareness amongst our clinicians and patients makes a huge difference to their overall holistic health. We know that monitoring of chronic diseases get better. Community engagement always leads to better health outcomes and overall understanding. And obviously to a healthcare system, it's better resource allocation that we need to work towards. So importance of health checks, early detection, so identifying those risk factors which are modifiable, such as blood pressure and cholesterol levels, working on prevention strategies such as lifestyle modification and interventions, and also, NHS England, we've all known about the personalised care approach, so tailoring health advice to individual needs in a way that matters to people. We all know about our CORE20 populations. We have published documents from the ICB about our clinical strategy for our clinical conditions, and the Better Health and Wellbeing for All documents. And we know that our CORE20 populations are rising in our region, and these are groups of individuals disproportionately affected by health issues. And obviously I've listed there the different groups, but there are many more. But I just am sure you will all agree that these are rising and increasing populations in the current socioeconomic landscape of our region. So I just wanted to stress what you probably already know and are working towards, that NHS health checks really do play a vital role in improving health outcomes and reducing disparities within our core 20+ populations, ultimately leading to healthier communities and better delivery of early prevention and intervention for patients that need it. Thank you for listening.
Thank you, Sarah. Really appreciate that, and an excellent summary of where we're at across North East and North Cumbria. So moving on to the next item of the agenda, I'd like to introduce Dr. Nez Robson to speak about her experience of running a Healthy Hearts clinic. So I'll pass over to you, Nez.
Hello, thank you. I'll share the slides now. Okay, can everyone see this?
If you could just put it on slideshow.
Is that okay?
Yeah, that's fine. Oh, Sarah, do you want to say something?
Yeah, you've got your speaker view on. We had the slide shared a minute ago if you wanted to use ours. Or
Okay, all right, okay.
do you want to reshare? Thank you.
If you just say next slide, please, then Nez, then Emma will sort us out.
Right, sorry about that. Okay, hi, I'm Nez and one of the GP partners in dental surgery. We're located in Stockton. So most of my figures and what I'll be explaining is mainly based in Stockton. I'm not sure what's in your each local area. Might be worth contacting some of these the people who are involved in your area in terms of finding your patients, what the funding is, and what kind of template you're using. But for Stockton, this is what we're doing. So I've been working with Tracy since around October, November last year. So I'm very much still in the process of finding the most efficient way to provide our patients with PocDoc with a healthy heart check. Okay, let's go to the first slide. Let's have a look.
Sorry, I'm just having some difficulties now getting it onto full screen. I'm just going to stop sharing and then reshare again.
It's on full screen for us, Emma.
Yep, that's worked.
Okay, so firstly to find out who are the patients that's eligible in your practice. My practice list is about 4,000, and we have about 1,000 patients who are eligible, which ties in with Dr. Malik's figures there, just around 25%, 20-25%. And these are the criteria is patients must be eligible. At the time of assessment, no previously diagnosed CVD condition, no statins issued within the last 12 months period. They will, if I'm using system 1, so they will come out on your homepage. At the bottom, there will be this eligible for NHS health check icon there, and that will tell you it's eligible. I got my list of our local team that runs the searches, and that was a really useful list. So if you are interested, I would advise you to get that list first and see what are the numbers you're dealing with, and work from there. For Stockton area, we were informed that the list of 1,000 patients that I have, it's aimed at 5 years. So the aim is to go through the list for the next 5 years. So break it down. So that's roughly about 200 patients a year. And out of that, 75% is the aim. So they don't expect us to go through everybody quickly, because there's also the funding issues around how much they can pay out every year. For NHS health check for Stockton, this is what they need. They need the blood pressure, BMI, HbA1c, the full cholesterol panel, GP physical exercise questionnaires, risk score. So CORE2 is on our system 1 and CORE3 is on the POC questionnaire. And then all C for alcohol risk assessment and also smoking status. Now, when you use the POC questionnaire, it's mainly catered for CORE3 questions. You will need to go into the NHS health check template to fill up all the other things that's on there to be eligible to click this off, essentially just to say that you've done it. Okay, the next slide, please. So again, this is for Stockton. I'm not sure if it's the same for other areas. The list, it will come in decile. So it'll tell you what group they are from 1 to 10. 1 to 3 are the highest paid because they are from areas that is the most deprived. It's completely up to the practices how they want to approach this list, whether you want to go by the area of highest deprivation, or do you want to go by age, people who are above 70 or above 60, that's completely up to you. For our area, so that's just to show you some emails that you can get in contact to get more information about how this is run in your local area. For us, we got the list from this website here. No, sorry, this email here. And when you do the NHS invitation, I'll explain this a little bit more in the next slide. We do read code as well when we invite them in, and when they decline, we read code that as well. This is for system 1. Next slide, please. So what I've done so far, the first one I did was ringing each individual patients up from the first group. Obviously, it took a lot of time. Explain to the patient what it's for. Some declined, some took it up, and and then I created a session specifically for POC docs, purely for POC docs, and attendance rate is a mix. So based on the amount of time we spent calling these patients up, I don't think the first method of ringing patients up is the most efficient for me anyways. The second one is we try to batch message using AccurRx, inviting patients in. So it's just a message, there's no options to respond, a little bit of explanation, but again, I don't think the uptake was that great. So I'm currently at the third one here where we create an AccurRx Flores questionnaire, and this is the template I'm using. I've tweaked the wording as well because initially it was, how to say, to a layman, for a normal person, they didn't quite understand what I was trying to say, even though I copied and pasted it from NHS website. So we worded it this way, and the response rate at the moment is about 20%. So I think that is the best that we've seen so far. And the time taken to do this is quite low. I do it once a week, and I get through about 50 patients a week. So this is where I'm at the moment. Anyone that comes up with a better idea, obviously, we can share that. So when patients say yes, I'm interested, it'll go into an inbox. Admin will pick that up, and then they'll ring the patients and book them in. If they say they're not interested, then automatically it'll get recoded declined. When I send this message out, it will get automatically recoded as invited as well. Next slide, please. So this is just a flow chart of what my practice nurse will do. So at the moment, I'm tasking my practice nurse to do this. So firstly, the patient comes in, they'll fill in the POC questionnaire on the tablet, where this takes about 5 minutes. Whilst the patient's doing that, the nurse will prepare the equipment for the POC for a lipid test and the HbA1c test. And the next step is to actually carry out the finger prick test. And the HbA1c takes about 5 minutes. POC takes about 8 minutes. So during that time, we'll do the checks. Check the height, weight, waist circumference, do the BP, do the pulse check, and go through the longer questionnaires, fill them up on the computer. And when the results are out, then we discuss. And after that, we'll input everything on the system. Signpost or refer, manual input. So this is a little bit that's a bit more work for us to do. So obviously it's a finger prick test. It's not on the system, so we have to manually input. So I've shown you here roughly. This is system 1 template. So you just type CHOL on examination, it comes out, Dropbox. Just click on it, and then it's documented. If it's not green like this on system 1, system 1 will not pick it up, and you will not be able to tick the complete box at the end. HbA1c, for some reason, it's not allowing millimoles, it's using percentage at the moment. Next slide, please. So this is our template for T-side. So while we're waiting for the POC-doc results and HbA1c results to populate, this is what we do, fill in everything here. Next page, please. And this will be the last one. So this is the third page, Curious 3 there, whether you start statin there. And this is the most important bit, really. If everything passes, you've done everything, you've ticked every box, you click this box and that's it, that's completed, and it will go off. If there's anything missing, it will come up with a window telling you what's missing.
Thank you, Nez. That's really interesting. Great to see a kind of real life example and walking through with that. So our final speaker is Tracy Marshall, and Tracy, I'll hand it over to you to introduce yourself and take us through the next part, which is reasons to take part.
Thanks, Mark. So as Mark said at the beginning, I'm a CVD Programme Manager with Health Innovation North East North Cumbria, and I'm also a pharmacy technician by background. So I have worked in acute trusts and in GP practices as well previously. Next slide, please. So why do we want to do healthy heart checks using point of care tests? So as kind of Ness has just demonstrated, we do get the results within minutes. So our point of care HbA1c at the moment takes 5 minutes. So kind of set that away first. And then the cholesterol one takes 7 minutes. There is a function where you can enter the HbA1c result into the POC-doc questionnaire while that's running. So that's kind of why we use that first. It's 1 finger prick, and we take 2 capillaries of blood, 1 for each test from the same finger prick, so we don't have to do that twice. One of the most important bits I find about doing these and having the patient there and getting the results kind of in real time, if you like, is the education about cardiovascular disease. As Mark mentioned earlier on, we have redeveloped our Healthy Heart Check booklet. That has also had input from a health literacy team. We've also added so it covers things like BMI, Q risk, obviously cholesterol, vascular dementia. We've also added in elements about chronic kidney disease and risks within the menopause as well. And all of that has gone through some a health literacy check to be able to kind of send that out to and go through that booklet with all the people that are sat in front of us and make sure that they kind of understand some of the risks and issues within CVD. As part of the new booklet as well, we're putting the results on there, and we're kind of developing a plan for that patient as well. So they'll take the booklet away and they'll have kind of a plan on a page, if you like. This hopefully re-engages patients back into the system. I've done quite a lot of point of care tests over the last couple of years, and what I've found people saying is that, you know, they didn't appreciate that having high cholesterol could lead to different health conditions. Obviously we do the blood pressure as well, and just trying to give them that holistic view of CVD and some of those risks related to it. Just kind of is a little bit of an eye-opener for a lot of people, and to try and get them re-engaged back into the system when they know their own risks. And obviously for patients which are overdue an NHS health check. So the extra questions like Ness mentioned there about the alcohol and exercise can be added to qualify for that extra reimbursement. And obviously with the CORE20PLUS5 indicators as well, there are more points for some of those CVD indicators as well. So it would also help with CORE. Next slide, please. So what we provide point of care cholesterol and HbA1c tests. We don't always do HbA1c tests when we're doing some of the outreach sessions, but we would do these within the GP practice sessions. We are able to provide the Samsung devices. So as part of POC-doc, to get the result, we need to take a picture of what looks a little bit like a lateral flow test. So the blood goes onto the lateral flow device, and then a picture is taken with that device, the same device that the healthcare questionnaire goes into, and all of that information is then populated within the app, within the PocDoc app, and then it gives you all of the results at the end. It takes into account lots of different healthcare questions to begin with, which Les kind of said takes about 5 minutes for them to fill in. The patient also, if they've got an email address or if they enter it into the PocDoc app, they will get a real-time result email of all of their results from that day as well. So as soon as the test develops, the patient will also get an email of all of those results that they can either print out or keep on their device. We provide training for staff, so we would come into GP practices and train staff on how to use the kit, and obviously answer any questions that kind of generates. We do ask, so we provide a data collection spreadsheet, so that is to be completed by yourselves. And what that gives us is an overview of the type of people that you're testing and making sure that we're kind of testing the correct demographic of people as well. And obviously we'll be providing that ongoing support. This programme currently is running till September 2026. So up until that point, we'll have ongoing support as well. Not sure what will be happening after that point. Next slide, please. So what we would ask of you, so we would ask for a member of staff to act as a point of contact. So obviously for Densham and Dovecot, we're very lucky to have Ness, and she's our point of contact there. We would ask you to identify appropriate demographic for patients. Obviously we can help and support that, and that will be different within each practice. But we could obviously signpost you and help with identifying those patients. We would need you to provide staff to perform the checks in clinic time, and obviously Ness has got some kind of real life experience of this, so I'm sure that Ness can kind of provide some pointers of that as well. I've personally done some appointments within GP practices when I was doing a pilot study for the targeted lung health checks last year, and a lot of the feedback from the patients was that extra kind of time that you spend with them is really important to explain about what's happening to them and what their risks are. We would ask you to act on abnormal results. Not usually keen on the term abnormal, but that is something that kind of comes up in NHS results. But obviously anything that's out with the normal or target results that we would like for cholesterol, blood pressure, HbA1c, etc. We would hopefully get completion of all the tests that we provide to you. So if we provide 100 tests, then hopefully kind of usage of all of those tests to be completed. And obviously, as I've already discussed, completion of that data collection spreadsheet. That would be anonymised as well. We wouldn't ask for any patient information or personal information of any of the patients. The next slide, please. So what I have done is we've developed a Microsoft form. It's very quick and simple to kind of fill in, and this is our expression of interest. So after you've been on the kind of webinar today, obviously we're going to have some Q&As next, but if you'd like to kind of discuss further, or if you've got an interest in this programme, please either scan the QR code, and I know that Sarah's put a link to that Microsoft form as well in the chat. So please, if you're interested, fill out that information and we'll get back to you as well. There is going to be a slight caveat onto people who are able to join the programme. Obviously, we're not able to fulfil everybody's request, unless we only get a couple of requests, which I'm hoping not. But obviously, if we get 50 kind of practices hoping to kind of join this programme, we would have to kind of look at the different areas that are in, look at the CORE20PLUS5, and have a staggered approach to be able to kind of to fulfil all of those requests. So thank you.
Thank you, Tracy. That's fantastic. And thank you to all of our speakers. We've been incredibly disciplined, which I really like to see. That we, I was hoping for 15 minutes, a minimum of 10 minutes for questions. So it's at this point in the webinar where I'd like to invite people to turn their cameras on. We'd like to open it up for some questions. So if people could raise their hand, and myself, Tracy, Dr. Malik or Dr. Robson will hopefully be able to answer any of the questions. So just while people are thinking of questions following the presentations that they have heard, there is one question in the chat from Jennifer Wood, and it says, when will we have an EMIS search to identify patients in the CORE20+5? So I know, Nez, that you mentioned about System 1, so I'm not sure if you'll be the best person to ask with regards to that. So an EMIS search tool to identify those. Syra or Tracy, do you want to jump in with that to answer that question?
That's a really good question. And what I would say is that we probably need to, unless Tracy knows of a way to do it. I know we individually in practices, have our ways of kind of running our audits and identifying our patients. But if there is a kind of want of this on a regional basis, we can certainly take it to our digital teams and have them kind of build something. Jack, would you say that would be a good way to proceed?
Yeah, I mean, it depends what's digital. I suppose CDRC is quite a popular one used across our region, so we could link in with CDRC to understand what the best search is that we can use that they could potentially set up. So yeah, just a bit of linking in that we can do.
Yeah, if I can just say, I've worked in Sunderland for a couple of years now, was in County Durham. We seem to be pushing this CORE20+5, but nobody can tell us how to identify those patients in a practice. It just seems a tool you're telling us to use, or something you're telling us to use, but not giving us a tool to identify those patients.
Yeah, no, I think that's a really good point, Jennifer, and I think that's something that we'll take away. We have as Jack mentioned, a CDRC search tool, so we can see if there's something that we're able to look at or develop. I know that Dr. Robson said that she was in the fortunate position of having that probably worked out, but I know that that's not the same across the patch, and that's one of the things that we're learning about with that variation. So can we take that away as an action to have a look at, and then we'll be able to come back to you and feed through those actions that we've taken? That would be great. Thanks. Excellent, thank you. Great. So over that, we've kind of got a list of hands that have gone up, which is great. So Naveed, you were first with your hand up. So if you want to ask your question.
Yeah, hi, thanks everyone. Great discussion there. Just on that topic regarding how do we even find these patients, that's an excellent question. I don't want to go back onto it in too much detail, but I will say that we've been doing very similar work at my PCN. EMIS appears to be really quite easy to locate the patients if we have a specific depth of coding. As long as the coding is relevant, we can find them on EMIS. System 1, however, is the problem. We can only put in criteria for up to a maximum of 100 patients. And if you're in a PCN of 80,000 or plus, that's not unworkable. So it's a lot more difficult to find patients on System 1. The reason I'm just bringing this up is because I actually requested a system development for System 1. Now that goes on how many people vote for it as to how quick System 1 will develop it. Because for me, it's an inequality within two systems, EMIS 1 and System 1. It's easy to do for EMIS, but not for System 1. So I would encourage people to specifically request a system development if you're a System 1 practice, saying that we are finding it very tricky and burdensome to do something that EMIS does very easily. That's all I wanted to say. Thank you.
No, thanks, Naveed. That's great. Thank you. Emily, do you have a question?
Yeah, if you've got something that you can share easily for EMIS, then that'd be great, because a lot of us are actually struggling with that across Sunderland, so that would be fantastic. The questions I had, though, and I apologise if you've said these, because people have been disturbing me throughout the discussion. So the point of care equipment would be provided as part of this, and you said that was until September 2026. So what happens after that?
So I'll jump in and answer that. So we have funding for a period of time, and so we have signed a contract regarding the point of care testing, the point of care cholesterol and the HbA1c test. So we have a certain number of tests. Then at the end of the program, like most programs, we have an evaluation, and that will go back to the Healthier and Fairer board at the ICB. And then beyond that, it's a bit out of our control to see if we're going to be able to get recurrent funding, or whether that'll be for the Healthier and Fairer board. So we have it for a period of time, and we'd love for GP practices and PCNs to be involved. But you're correct with regards to we can provide the point of care testing.
Yeah, I think it's one of those things that gets frustrating, doesn't it? Because we've had point of care testing before in practices, and then it went away, and then it's coming back, and then it'll go away again, and it's just a frustration rather than anything that you personally can do anything about. And then the other thing I just wanted to ask, if I can have one more question, is just, I know there was discussion about sort of limiting how many NHS health checks we could actually do a year because of the funding associated with that. And I know this year, as Sarah said, Sunderland did really well and did loads of NHS health checks, which in theory is really good, but then there was a query about whether we were going to be restricted because we've done loads of them. Is that going to impact on this or not?
I would say check with your local council, check with the person, the team that funds this, because in general, they don't expect everybody to do 100% of all that's on the list. So the funding in general is adequate. But if you are intending to do more than what they think you will, then just give them a heads up so they know.
Thanks.
Because again, that seems a bit of a barrier, doesn't it? If we're then going to be part of a programme, try and get everyone done, and then go, well, actually, you can't do them.
Yes. Sarah, do you have anything you'd like to add to that, or?
No, Emily makes a very valid point. We know there are financial constraints across all the systems. We actually don't really know what's coming our way. So it's something to watch in the next 6 to 12 months, what happens in terms of our local healthcare systems. I would continue to push to do as many as possible. And the conversation about funding will need to happen, and we can certainly raise that with Jerry Taylor and the team at Sunderland. And we know there's never going to be 100% uptake, Emily, but the more we try and push it out, at least we may target that particularly vulnerable population that now we're not engaging with at all and have the poorest health outcomes.
Thanks, Sarah. Naveed, I just want to confirm, is that a legacy hand or a new hand?
Legacies, sorry.
Legacy, sorry, that's fine. Thank you for that. Matthew?
Hi, yeah, just want to go back to that identification of the cohort, that work that could potentially be done, and also just dovetail that with Nexus searches they provide, because I've found over the years when we do NHS health checks that aren't on their lists, they're not interested in any kind of reconciliation of those. And so I've stuck to those over the years. So if there's any identification of others, I don't know whether they're going to kind of look at those and be sympathetic towards that. I don't know how much discrepancy there would be between those searches and those ones that they provide. And I've also noticed that Next searchers up until recently weren't pulling off QRIS 3s. So there's lots of, I suppose, some of the work that we're doing the work, and we're struggling then for the Next, whoever extracts it and then goes to the council to pay to kind of have those discussions. So I don't know whether there's anything you can do regarding that, if you're going to do some additional work on this to try. Certainly in South Tyneside we're very low on the uptake anyway. But those are things that we're coming across as well, that I'm not saying it's a barrier, but I suppose if you're not going to get recompense for the work you're doing, it becomes a bit of a law of diminishing returns.
Yes. No, thank you for that, Matthew. Yeah, I agree, and I think that's a theme that we'll take away from today. I want to get through as many questions as possible. So, Ruth.
Hi, yeah, mine's a quick one, please. How onerous is your data spreadsheet to complete?
Tracy.
Well, I've done it personally because I go out and do the outreach sessions, and so myself, and we've got a project support office as well. It takes, I don't know, a minute per patient potentially. Ness, what would you say that you've less
I'm
than that.
happy to
It's
share
literally
it
just
quickly
dropped down. Yeah,
I can share it because there's no patient identifiable
no.
there anyway. I'll share the screen just really quickly.
And the information is kept on the PocDoc app for 7 days, so it can be done retrospectively as well. So it doesn't have to be done there and then. You'll kind of set 15 minutes to one side at the end of a clinic and just kind of input all of that data. So what I tend to do if I'm out in the outreach bus on a Friday, either myself or Christine kind of puts 15 minutes to one side on Monday morning, and we input it then. So all of these sections have like a drop down tab, and we just kind of what we're doing is we're putting it within certain ranges. So we're not asking kind of to put exact details in, just kind of which ranges those people would come under. And then if we've kind of done in signposting, and obviously in certain GP practices there will be outcomes as well, which kind of Ness is kind of highlighting there as well. Then that automatically pre-populates a dashboard, which is on a different tab. And that just gives us an overview of kind of how many we've tested. And it kind of it's got a couple of graphs and things in there, how many we've tested, what the demographics are and things like that. So hopefully not too onerous, but happy to take feedback if it does become that way.
Okay, no, that's great. Thank you.
Thanks, Ruth. Excellent. So it's been great to see in the chat there's a number of questions. What I'll do is we'll commit to reply to those answers. It might be the first 5 minutes after the webinar. There's a couple of questions that I think is useful. So Gwyneth has asked Nez, in your presentation relating to the criteria, there was something about 5 years. Can you just clarify what this was, please? Was this the council hoping that they've identified 2,000 patients or 800 patients, but they're to be seen over a 5-year period? Was that what it was in relation to?
No, if it's about the first slide, it's just eligibility. That's the criteria for the patient to be eligible for the NHS health check, that they shouldn't have any CVD diagnosis or any kind of been commenced on statin for the last period of time, a certain period of time. If they have been started on this and stopped, they will not be eligible for it. It's quite clear on the list of patient eligibility as well, where it shows whether they are they fit the criteria or not. But the 5 years funding, that's a separate issue. So the list that you get is the total amount of patients that's eligible, but you have 5 years to get through it for funding, basically.
Excellent. Thanks, Nez. And the last question that we'll have is from Louise, which says, we already do NHS health checks with Newcastle City Council. What's the difference? And it might be that Jack and Syra know. It could be that they're focused on workplace, and this is more focused, on CORE20, and those 20% most underserved populations, but that might not be correct. So Jack and Syra, would you like to come in on that?
Yeah, so the health checks are the same. They are the ones contracted with the local authority, but there's quite a variability across our region. So, Louise, you're doing incredibly well if you guys are already doing it, because we know from the stats shown for Newcastle, Newcastle was one of the hotspots where the health checks weren't being done, compared now 2025 to 26. When we compare the data from 23-24, there has been a sudden jump in increase in health checks being done in the past 12 months. So this is really trying to understand how we can help better support practices. What are the barriers to practices engaging in health checks, and is there anything we can do from the ICB to support that? Obviously, we work with Health Innovation to broker those, external deals, which will help facilitate us getting out to the community more and using different methods to engage with our population. But they are the same thing.
Yeah, just to add as what Syra said there as well. So it is the same as what's happening with the council, but as Mark said before, it is around that bit more of a targeted approach into the CORE20 communities and more deprived areas, etc. But just back to the comments someone mentioned earlier about the cap with the council as well. From being part of the local authorities NHS Health Check Network, I don't think any local authorities ever reached that cap where they wouldn't be paid anymore. So despite numbers are increasing for the NHS health check, it depends on the spec for your local authority. So I'd encourage you to contact them to ask. But from what I've heard, nobody's ever reached the cap anyway, which is good news in terms of funding.
Thanks, Jack. I'm aware of time, but Mike, I'm aware that you've got your hand up. So last question, please, from yourself.
Hello, thanks. A quick one, thanks. I just wanted to elaborate on Naveed's comment earlier with regards to acquiring your CORE20 list. We found that you can use Radar to get a list of your patients in deciles 1 and 2, which you can then export. The issue we found is that you can import this entire list back into EMIS in a format that you can work with, but you're restricted with System 1 in terms of the numbers that you can import. So I just wanted to clarify that point there. We're halfway there for our EMIS practices in the PCM, but we do have an issue with our System 1 sites at the moment.
Thanks, Matt. That's really helpful clarification. So we'll go away and have a look and see, but it's helpful to know about the radar data and identifying those from deciles 1 and 2. I just want to, because I'm cognizant of people's time, etc. I just want to thank everyone for coming along. It's great to see so many people on the call today. I want to thank each of our presenters and just to kind of finish off with, because I know there's been a number of questions in the chat which we will answer. Please fill out the Microsoft form to register your interest. We'd love to get back in contact with you. As Tracy says, we would love there to be great demand, across the system for providing these healthy heart checks, and we'd love to come alongside you and work with you to help support the delivery of that. So if you could click on the form, please, and complete that, and we'll get back in contact. And I'll bring the webinar to a close and just thank everyone and have a good rest of the afternoon. Thank you.